Hello everyone, this is Team 2's Integrative and Allopathic Summary and Proposal Presentation for Major Depressive Disorder. The collaboration of efforts represents our common goal of using evidence-based practice and recommendations for the treatment of major depressive disorder, or MDD. In this presentation, we hope to offer insight and give the reader an understanding of the significant impact of major depressive disorder on the quality of life in those diagnosed, as well as interventions to consider in treatment planning, including both integrative and allopathic treatments.
Depression affects more than an estimated 264 million people globally and more than 19 million American adults. This places depression as the leading cause of disability in the United States. For the World Health Organization, the illness is associated with increased mortality and many negative health outcomes. Major depressive disorder is defined by the Mayo Clinic as a mental health disorder characterized by persistently depressed mood or loss of interest in activities causing significant impairment in daily life. And I'll go into the diagnostic criteria in the next slide. But to mitigate the loss of daily function and quality of life from major depressive disorder, establishing clear and effective treatments is of utmost importance. Primary providers play a critical role in major depressive disorder, as approximately 45% of patients who commit suicide have visited their primary care provider in the previous 30 days. Diagnosing major depressive disorder is not as clear-cut as some other diseases such as diabetes. This is partially due to the fact that the pathophysiology is very complicated and not well understood, and presentations of major depressive disorder can vary widely from patient to patient. Some may have more mental or emotional symptoms, whereas others may have more physical symptoms. For the DSM-5, to make a diagnosis of major depressive disorder, a patient must be experiencing, for 2 weeks or greater, depressed mood or loss of interest or pleasure in activities, plus other associated symptoms such as diminished ability to concentrate or think, insomnia or hypersomnia, psychomotor agitation, significant weight loss, or other symptoms. A patient must have 5 or more of these symptoms to be diagnosed with major depressive disorder. Because the pathophysiology of major depressive disorder is not well understood, treatment can be really challenging. While 2/3 of patients receiving standard treatment elicit a positive response, the remaining third do not attain adequate remission from their symptoms and may repeatedly cycle through depressive episodes. After an initial episode of major depressive disorder, the rate of reoccurrence reaches 40%, and after 2 episodes, the reoccurrence rate escalates to 75%. Because of this non-response issue, it leads to the need for additional or alternative therapies for major depressive disorders. There's also been some push to shift the framework of treatment for major depressive disorder. What is considered successful treatment may vary from patient to patient. Successful treatment should be viewed on a continuum rather than black and white criteria. Giesecke and Nelson Becker, 2018, state changing the framework has shown to have positive implications for practice. The term treatment resistant has been described as a label and thought to be detrimental to depression remission outcomes. McAllister and colleagues have recommended using the term difficult to treat depression instead. So the shift from treatment resistant to difficult to treat allows for a more realistic and attainable picture and a chance for partial remission and ultimately improving patient outcomes. Patients' preferences should also be considered when determining the acceptable level of recovery. While the improvement in neuroscience and development of better allopathic treatments ensue, current guidelines for clinicians are geared towards the goal of complete remission of symptoms. And because of the burden of depression and other mental conditions is on the rise globally, it is critical we better understand treatment options for the large portion of patients who have treatment-resistant major depressive disorder.
The PICO our group chose to compare integrative and allopathic treatments was: in adult patients with major depressive disorder, how does solo acupuncture compared to pharmacological therapies decrease symptoms of depression? For the integrative and allopathic literature reviews, we utilized the American Psychological Association, the World Health Organization, the DSM-5, and the Health Quality Canada websites to expand our knowledge on the diagnosis, statistics, and treatments for major depressive disorder. In addition, we utilized our wonderful MSU librarian, Marianne Hansen, in finding the most relevant research for our PICO. For our integrative review, searches were limited to peer-reviewed literature within the past 5 years. To minimize confounding variables, criteria focused on acupuncture in the general population, excluding studies focused on subgroups of the population, such as post-stroke patients and menopausal women. 20 research studies were initially selected, with 7 studies removed as they were determined duplicate or inadequate to answering our PICO. The appraisals were specifically selected to understand what current research is conveying about the topic of acupuncture as treatment for reducing the symptoms of major depressive disorder. For the allopathic review, our group limited peer-reviewed literature to the past 8 years, guided by the DSM-5's most recent update being 2013. Our criteria focused on current treatment for depression in adults in the general population. Again, studies that focused on depression in subgroups of the population were excluded. 20 studies were initially selected, with 15 kept for review. Utilizing the evidence hierarchy, our literature search focused on the strongest available evidence, Level 1 and Level 2 studies. We incorporated a pragmatic design study in our integrative review, and case studies, a case review, and expert opinion for the allopathic review as additional evidence guiding best practice. Systematic reviews and meta-analyses demonstrated overall inconclusive evidence with the use of acupuncture in treating major depressive disorder. Future research recommendations included larger studies with standardized measures and improved methodology. In these reviews, acupuncture was often included in complementary and alternative medicine studies, making it difficult to analyze as a separate intervention. In the randomized controlled trials reviewed by our group, however, high-quality evidence was demonstrated, including adequate study methodologies producing statistical significance and the utilization of appropriate comparator groups and measurement tools. The reviewed randomized controlled trials demonstrated statistically significant reductions in depressive symptoms, although clinical significance was often not addressed. All studies confirmed acupuncture's low side effect and risk profile. With acupuncture's growing acceptance in the United States, it offers providers a reasonable and safe treatment option for major depressive disorder patients, especially in those patients resistant to current therapies or riddled with medication side effects. Given the need for higher quality studies and more conclusive evidence, however, the use of acupuncture as a solo treatment in MDD should be guided by patient preference and provider discretion.
Allopathic treatments of major depressive disorder primarily focus on pharmacological therapy. 3 systematic reviews appraised discuss that to better research pharmacological therapy for major depressive disorder, we must also work to better understand the pathophysiology. Researchers seek to understand optimization, augmentation, combination, and switch therapies. Through appraising 6 randomized controlled trials relating to allopathic treatments of depression, we found the effects of including pharmacists in treatment planning on patient and medication adherence reveals promising results. While the study does not yield statistically significant improvement in patient response to treatment, shared decision-making has been shown to positively affect patient outcomes. Many researchers tested the safety and efficacy of adjunctive treatments for patients with difficult-to-treat depression. Gundas, Bruce, and colleagues' 2019 report deficits in GABA may be involved in the pathological process of depression. The trial demonstrates statistically and clinically significant improvement in HAM-D scores after 15 days with the addition of Sage 217. The quick onset of symptom relief for patients who previously failed to reach therapeutic levels with antidepressants was noted. In 2019, Papuva and colleagues tested switching patients to a new SSRI or SSNI and utilized a rapid onset medication, esketamine, in the placebo-controlled study on patients with difficult-to-treat depression. Medications like esketamine may quickly provide a safe and effective reduction in depressive symptoms, which could be really important for patients with suicide ideation. The researchers added adjunctively using ziprasidone, an atypical antipsychotic, showed statistically and significantly decrease in HAM-D scores as well. Sage 217, esketamine, and ziprasidone offer options for patients with difficult-to-treat depression. The addition of cognitive behavioral therapy in patients with difficult-to-treat depression was also noted in multiple randomized controlled trials. One study reveals statistically and clinically significant decreases in the GRID HDRS score at 16 weeks and 12-month follow-up for patients using cognitive behavioral therapies as an adjunctive therapy. While time and payment considerations may limit the use of CBD for some patients, the efficacy and low to zero side effect profile offers an option for difficult-to-treat depression. McAllister Williams and colleagues 2020 and Rush 2019 worked to define and shift the current framework of difficult-to-treat depression. The researchers urge to change the goal to be optimal symptom control, daily psychosocial function, and quality of life. They suggest the treatment goal should be improved functionality in daily life rather than complete remission. The 2010 clinical practice guideline titled Practice Guideline for the Treatment of Patients with Major Depressive Disorder by Gallenberg and colleagues is broken down into 3 sections. Part A, treatment recommendations, Part B, background information and review of available evidence, and Part C, future research needs. This was done so different readers can easily locate the information most useful to them. This guideline is very comprehensive as it addresses the recommended treatment options for the many stages and various causes of major depressive disorder in adult patients. The recommendations are broken down into 6 categories, including 1. Psychiatric management, 2. Acute phase, 3. Continuation phase, 4. Maintenance phase, 5. Discontinuation of treatment, and 6. Clinical factors influencing treatment. To appraise the CPG, the Agree-To tool was used. This CPG was given an overall rating of 6, but the 6 domains scored differently. Domain 1, Scope and Purpose, had mixed results. The authors neglected to include health questions covered by the guidelines. Domain 2, Stakeholder Involvement, scored high overall, but was lowered because they did not include pharmacist input. As I discussed earlier, research is beginning to show that including pharmacist input can improve patient medication adherence and overall outcomes, so it would be important to include this. Domain 3 looks at rigor of development. The fairly strong rating of this domain reflects that the authors used rigorous systematic methods to search for and develop evidence-based recommendations. Criteria for selecting the evidence wasn't completely specific, but the authors did discuss that this guideline has a broad scope, which could explain why the selection criteria was not very specific. Domain 4 appraises clarity of presentation. The clinical practice guidelines scored very high in this domain, as the organization and presentation is very clear and concise. Domain 5, applicability, scored strongly. A very detailed description of treatment for all stages of major depressive disorder and the various methods of treatment are discussed in detail. Domain 6, editorial independence, scored straight 7s. The authors extensively and thoroughly explained this information in the section titled Financial Disclosure and Conflicts of Interest. Although not all domains were given a 7 rating, overall this guideline is of high quality and would be recommended for use without further modifications. So the rating overall was a 6.
For the appraisal of the clinical practice guideline and depression, we used the American Psychiatric Association APA 2019 guidelines. These guidelines give the highest level of evidence-based practice recommendations for clinical practice using systematic review of all scientific evidence available, and they also pay close attention to making sure it is across the lifespan with children, adolescents, adults, and older adults. The American Psychiatric Association is the largest and most renowned psychiatric association in the United States as well as the world, with nearly 40,000 members and people participating in gathering the evidence to make sure that we have the best level of care for patients using the highest quality of evidence. Our overall rating of the APA 2019 clinical practice guidelines using the Agree-To tool is a rating of a 6 out of 7. We recommend this for clinical practice for all practitioners and providers of psychiatric patients, and we would highly recommend using any of the guidance within the clinical practice guideline. We found through our evidence summary that it's important from the patient's perspective to have a trusting relationship with their provider where they sense safety, unconditional, positive regard, that they feel that the goals between the provider and themselves are mutual goals, so they feel understood. This helps diminish stigma associated with mental illness and gives that perception that depression, regardless of severity, is manageable through looking at levels of remission and finding that best outcome possible to optimize that patient's level of functioning and getting them to a place where they feel they can participate in their lives. We found that it is important from a clinician perspective to provide a safe environment, to work to maintain a therapeutic alliance using stigma-free, trauma-informed approach, providing empathy, but really importantly, providing a straightforward and clear expectations and guidelines for the patient so that they can sense that their condition is manageable and they can have varying levels of remission where they can gain functioning in their life. Our team found that the recommendations for people with major depressive disorder include a combination of treatments. Usually there should be some form of psychotherapy. Usually CBT, cognitive behavioral therapy, is really effective. Using medications, using mind-body medicine, such as any integrative approach. Our team studied acupuncture as an integrative approach, just as an example of what integrative could be. You could also look into other mind-body medicine approaches such as yoga, walking, exercise, dance. Then for the varying levels of the continuum of severity for depression, if patients need more, if the psychotherapy, the medication, the mind-body, and all these things are not proving to provide more functioning in the patient's life, we can start to look at other options such as brain stimulation, ECT, and things like that. The clinical practice guidelines that are out there right now recommend that when you have someone with diagnosis of major depressive disorder, you have a start point of using an SSRI. Now that's just in the recommendation. If a patient comes to you and they have a family member that uses an SNRI because there's such a genetic component, you may start with an SNRI or some other antidepressant. But in typical straightforward terms where we have these 8 easy steps sometimes to fix things, we usually start with an SSRI, a serotonin, a selective serotonin reuptake inhibitor. Those are effective in about 70% of cases. If that doesn't work, sometimes they'll switch to another SSRI just to see if that works better. And if not, then an SNRI or some kind of atypical antidepressant, antipsychotic sometimes works. In the research, we found that it's actually pretty rare for a patient to have only major depressive disorder. Usually there's something else going on with the patient, and when you use an atypical and find that that works, you can pretty much demise that there's more going on for that person in their brain chemistry than just straightforward depression. If those things don't work, however, you can keep trying. You can try a combination of drugs. You can try tricyclics. I will say with tricyclics, it is really important to be careful with your safety plan, as tricyclics can be fatal in overdose. So if you have a patient with a history of suicide or a suicidal ideation currently, it would not be a good idea to prescribe tricyclic antidepressants. Bupropion is a brand name Wellbutrin. That's another drug that is not an SSRI or an SNRI. It's kind of in its own class. They're more of a have a piece of dopamine adrenergic reuptake. Sometimes people with anxiety or things like that will be triggered by bupropion or have insomnia and things like that. So just be really careful when you think about these things, how you are making your decision. So once those things don't work, you may try combinations of things. You may actually end up trying lithium with a patient. You also want to continually and simultaneously. So again, these things aren't necessarily in order. You're going to make a unique plan for each patient based on the information that you have in your thorough assessment. You are going to be continually and simultaneously educating the patient, exercise, nutrition, sleep hygiene. You may refer them, and you should refer them, to some kind of psychotherapy. Our research found that CBT, cognitive behavioral therapy, is very effective, and in some cases is effective enough to not need anything else. So continue to look at your patient, form your therapeutic alliance, make decisions based on their unique needs, and then follow up with adjunctive or other types of integrative therapies as needed, such as acupuncture. Continuing on with our recommendation, it's important that the nurse provider uses the nursing process in their shared decision making. We should continually be assessing, diagnosing, planning, implementing, and evaluating our implementations and our assessments and seeing how that patient has maybe improved a little bit with their functionality. So we need to address our treatment plan and adjust that treatment plan based on that patient's needs. So how they're responding, what are the side effects? What's the severity of the depression? Do they have comorbidities? For example, if you're giving somebody a atypical or an antipsychotic for their depression and that's working, you want to check their comorbidities. These drugs can have really detrimental effects on people. If they already have diabetes, it can make it worse. It can cause some glucose control issues. So we want to look at other drugs these people are taking and reconcile those medications so that we make sure we're not causing more adverse or other side effects based on their current profile of comorbidities and current medications. We want to assess safety always. Safety, safety, safety. Is there a suicide risk? We want to make sure we're not putting a patient on any medication that increases their risk of being able to have a fatal overdose, or looking at their history of family history of suicide attempts and acting accordingly with that. Safety plans are really important. We can have a patient, they have black box warnings for these medications whereby it is figured out that a patient who may have been depressed, their brain functioning is really down, so that's their cognitive functioning is slower. They may now have the energy to carry through with their plan because of the medication. So we want to make sure to have a safety plan in place. In summary, we want to say that, again, the role of primary care in depression screening and suicide is critical. Patients who commit suicide 45% of the time have seen their primary care doctor within 1 month of their deaths. We need to continually be assessing our patients for depression and suicidal ideation using screening tools and then acting on that information with the resources we have available. In summary, a return of depression symptoms should be carefully monitored. The risk of relapse from a depressive episode is highest in the first 6 months following recovery of a major depressive episode. We as providers need to plan to adjust treatment as needed for that patient's unique needs. There really is no definitive approach to discontinuing or tapering psychotherapy meds. It is so unique to the patient. There are some recommendations that say you may attempt a discontinuation trial within 6 to 9 months. However, there are patients that may need maintenance treatment, and there is nothing wrong with evaluating that and looking at ways that we can maintain a patient's level of functioning using our psychopharmacology and our other tools. Thank you.